Fighting Blindness Canada's Viewpoint is an education series that brings you the latest in vision research presented by health experts from across Canada. The session you're about to watch is a recording. To learn more about the research we fund and upcoming events, please visit our website at fightingblindness.ca. This Viewpoint is proudly presented by Bayer and supported by Abbvie, Apellis, Astellas, Biogen, Janssen, Novartis, and Roche. Thank you for watching. We hope you enjoy this session and share your thoughts with us in the comment section below.
So as we heard, but for anybody who maybe missed the first session, Dr. Paul Yang is the chief of the Paul H. Casey Ophthalmic Genetics Division and Martha and Eddie Peterson Endowed Professor at the Casey Eye Institute at OHSU. And he has a specialization in inherited retinal degenerations, as well as being a principal investigator on many different gene therapy clinical trials, as we heard. And then we're also really excited to have Dr. Kirk Stephenson. He is a retina surgeon who also has a special interest in IRDs, which is why he's with us. He's currently in his second year of medical and surgical retina fellowship at UBC. He's originally from Vancouver, but he went to medical school and did his ophthalmology residency in Ireland. And in July, we are lucky that he will be relocating to Toronto temporarily to complete inherited retinal disease fellowship at Sick Kids. So welcome to both Dr. Yang and Dr. Stephenson. So this session is called Ask the Experts. And so that's really what the whole session is about, is getting your questions for Dr. Yang and Dr. Stephenson. So I always have questions in my back pocket, but I'm going to open the floor up right away. So if anybody has a burning question, please. We have 45 minutes, and it's all for you. So I see JJ coming around to the center here.
Hello. My name is Rumila, and I have a question. It's related to, I have retinitis pigmentosa. I know my gene is PHYH. However, my retinitis pigmentosa is caused by Refsum disease. So there's an added layer, and I'm not sure if any of the clinical trials that are happening would be applicable to someone like me, or what I have.
I'll let you start.
Okay. So for retinal gene therapy, not aware that we've got something close, but as I was saying earlier, there are strategies that we're researching where it doesn't matter, what kind, of degeneration you have, and so, and that is basically kind of cell-based treatments or optogenetics, wherein we try to rehabilitate or try to restore, but more work. Right, still needs to be done in those categories.
Yes, as far as I'm aware, that's correct around the world. I spent some time in Ireland as part of my training, and
use the mic, please.
Can you hear me there?
That's better.
As part of my time in Ireland, I was fortunate to meet only 2 people that were affected by Refsum disease, and I know that in an early diagnosis in childhood, there are some dietary modifications that may delay the onset of both eye and rest of the body effects. But I think the gene agnostic approaches, which is the not requiring a genetic diagnosis, may be the most promising in similar situations.
And I just wanted to remind any of the online participants, if they have questions, you can put them into the Q&A box in Zoom, or you can email them to education@fightingblindness.ca, and we'll also take some questions from the online participants.
Hi, my name is Mark Anson. I have a couple of kids with Ushers. I just have a question about you're doing research, which thank you very much, which is rapidly expanding. What are some of the kind of the largest hurdles that you're facing? Is it about financing or facilities or access to the drugs or skilled researchers? What are the hurdles that you're facing right now?
That's a good question. I think maybe I can answer it in different ways. When it comes to, say, gene therapy, right, we work with companies to, do these clinical trials. And, maybe one way to answer that question about hurdles is, why don't we have more, gene therapy programs for all the other different genes? Well, it's, part of it is because, gene therapy, how we're able to achieve it, on a technical level is dependent on the strategies that are available. Certain genes are easier, to develop gene therapy for, right? Smaller genes of a certain size that fit into adeno-associated virus, AAV, which is the most common viral vector that we use. Genes that cause, either X-linked or autosomal recessive disease, in which it's more of a deficiency, right? It's easier to imagine that delivering a good copy and augmenting, the genetics will help the disease. Genes that are much larger that don't fit into AAV, we have to use different strategies. Genes that are, that cause dominant disease, it's harder to do because you have to actually silence whatever malfunction is going on due to that gene. So it really kind of depends on the disease type, the genetics of it, and the size of the gene. And so no one person is going to figure that out. It requires the entire field to advance techniques for gene therapy, and also advance our understanding for every condition of what's going on when you have recessive disease, dominant disease. Yeah, good question, big question.
Yeah, there's lots of points to that. Two major issues I can see are diagnosis, number one, and then the approval process for these treatments. So we know of hundreds, approximately 300 genes that are associated with inherited retinal disease. And although 20 of them represent most people, we only get a diagnosis from a standard genetic testing approach in about 60 to 70% of people, depending on the condition and the type of test used. And a participant here mentioned earlier they've gone through several rounds of genetic testing and still do not have an answer. And this is not an uncommon scenario. So in those situations, we may be limited to cell-based and neuroprotective therapies. And then from a regulatory point of view, while something may work really clearly, theoretically on paper, in reality, the visual gains may not be those that we're measuring. So tests like visual acuity of what you can read on a chart, although some of the studies that you spoke about were very promising because there was a 3-line improvement on the chart, some people will not get that improvement, but they'll have other noticeable benefits to their vision. So different testing techniques like FST and the multi-luminance maze that we saw the video are ways to try and prove to the FDA and Health Canada that these treatments are making a difference that's real and valid. Because there are safety concerns if you're giving a gene therapy that involves a surgery, which has risks, infection and retinal detachment and so on, and also the cost of these treatments not only to develop, but to fund publicly through our provincial health system. So there's a lot of barriers, even if something makes a lot of sense, and there's a lot of drive and need to have these treatments.
I have a couple of questions from online, which I think are a really nice follow-up. So one of them is from Jay, who was a follow-up to something that Dr. Yang said about the size of the gene. And he was saying he didn't realize that genes were different sizes. So I was wondering if you could just describe a little bit what that means.
Yeah, so genes are made out of base pairs. So you can kind of count how many base pairs a gene is composed of. And so there's a wide range, right? We have so many genes in our body that's, basically the instructions, right, for making proteins, right? And so simpler proteins, shorter proteins, right, they can be instructed to the cell can make those proteins with shorter amounts of base pairs, basically shorter genes to define those proteins. But some of our proteins are really complicated and long, and so of course those are larger genes. And as I was saying earlier, AAV, which is used in almost all the gene therapy clinical trials, they just have a maximum capacity. And so for all the clinical trials that I showed that uses gene augmentation, which means we're delivering a full copy of the gene to the retina, it has to fit. It has to fit in the AAV. There are some genes that are about twice the size of the limit. Okay, and there are new strategies coming down the pipeline now where you can cut the gene in half. Okay, it's called dual vector approach. You can basically cut the gene of interest in half, delivered in those two halves to the retina, and then the DNA, the two halves of the DNA would come back together, form full DNA, and then you would have your gene that you would use to make normal protein. There's even another strategy now where the two halves are delivered, okay, and then the cells go on to make two halves of the protein, and then the protein comes back together and forms a full-length protein. We call it splicing. And so there are sophisticated, kind of second-generation strategies coming along that are, expanding our repertoire.
Thank you. And this is a follow-up to something that Dr. Stephenson said, which was about the potential risks versus benefits of gene therapy. And the question is a bit broader. It was wondering about the risks for both gene therapy, but also cell therapy. So for instance, could either one of those cause unwanted cell growth? What other risks could they be? So how do you sort of balance those two things?
What a great question. So it really depends on the mode which we're planning on introducing either the cells or the new gene into the eye. And there's a number of routes. The one commonly spoken about, which is used for Luxturna, is through a vitrectomy operation. And this involves coming from the front of the eye and basically reaching through the clear center of the eye to reach the retina, and then taking those AAV vectors loaded with the correct gene and injecting them through the retina in a tiny opening to get the gene into the right place. And the risks of this are present but low. So we do this operation for other reasons, for retinal detachment, which is a visual emergency, and for lens surgeries where there's complicated cataract. So it's something that's done very frequently, and in most centers done every day, 50 times a week. So despite the frequency of these surgeries, the risks are low. Things that could happen are cataract development, which is something that's treatable in future. Retinal detachment can develop, or infection would be the top things. But we're talking in the order of 1 in 100 chance to 1 in 5,000 chance, depending on which you're talking about. But there's other approaches that have been used, including intravitreal, so similar to injections that people may get for macular degeneration, which I'm sure they're talking about next door. And there are risks to this as well, mainly infection. And what we've seen, I know you have personal experience with this, Dr. Yang, with the RS1 gene therapy, is the pronounced ocular inflammation caused by introduction of this new substance and virus into the eye. And then there's some plans, and I believe early phase clinical trials of suprachoroidal delivery for certain genes. So it's a different type of injection that doesn't go as far into the eye. So there are risks, and we have to balance those risks with the chance of benefit. So is someone having a rapid change in their vision, like the first young patient that you described, where they have a measurable reduction in vision over only a year? Or is this something that's more stable and the risk is higher than the benefit? So it's really a case-by-case discussion for every single person based on the multitude of variables in each case, from the gene to your visual function to other health conditions. So It's amazing what we can accomplish, but we have to proceed cautiously always.
And maybe I can just follow that up with the question about could either the gene or cell therapy lead to unwanted impacts such as excess cell growth because these are restorative or proliferative treatments?
Good question. I mean, I think for cell-based treatments, right, these cells are not completely differentiated. And so that is, one of the safety things that all of the clinical trials are monitoring. And so far, the universal theme is that it seems to be safe. These cells don't seem to multiply or grow, in a way that becomes uncontrolled. It's actually the other way around, right? What we're seeing is that those cells just don't stick around, it seems. We're not sure, even in the cases where there's material there, when you image the retina, whether or not those cells are functional or integrating. And as I showed and talked about earlier, the issue is the opposite. It's actually the cells get lost. They get cleared probably because of your immune system.
Thank you. So how about it back to the room? We have a question over there.
Linda has a question. Thank you. My name is Linda. I'm a senior, and I've lived with RP for over 70 years. Have virtually no retina function left, tiny bit of light perception at times. I understand that the main thing that's out there for someone in my position is this optogenetics, and it sounds quite exciting, and I'd like to know more about where the clinical trial is going with that in Canada. I know that they're further ahead in the States. When can we expect to see this being of benefit? Haven't got another 20 years to wait, so yes, thank you.
Thanks for your question. In Canada so far, at least in British Columbia, there is no access to a clinical trial for optogenetics as far as I'm aware. And Dr. Yang may have more about how Canadians can access clinical trials in the States. However, I think the reality may be that once such a treatment becomes approved by the FDA and then by Health Canada, we may be able to access it on a post-approval basis there. But I'll ask Dr. Yang.
Yeah, sure. So probably a couple of ways I could answer that. I think I would say, there are a group of companies that have been working on optogenetics for quite some time. And probably the one that is just a little bit further ahead is a company called Nanoscope Therapeutics. They completed their phase 2 clinical trial for optogenetics in retinitis pigmentosa. And they recently released some quite compelling data that on average they were able to get a significant level of vision gain. And not that patients who had very severe vision loss were able to always read the chart again, but there was still an improvement, even if patients were still kind of in the low vision category. But the numbers, looked quite compelling, and they're planning to go to the FDA with that data to see whether or not they can get any kind of early approval. So we don't know yet. It may be that they'll have to do a formal kind of phase 2/3 clinical trial. So if there is some kind of early approval, right, that may, mean that, would Canada follow suit at some point? If it ends up being a phase 3 clinical trial, it'll probably, take another 3 to 5 years, right, to enroll all the patients, have enough data, right, analyze all the data, submit it to the FDA, and go from there.
And I might just add a point, aside from optogenetics, for people that have quite advanced retinal degeneration, there are some other options that have been studied in different parts of the world. So I know in Australia and the UK, the concept of artificial retina has been investigated. However, as of late, it is not as well discussed. Essentially, what this involved was quite a large surgery to put essentially a microchip under the retina, and that connects to an external camera that is integrated into the optic nerve. The quality and level of vision was very limited from this. So think that you have millions of photoreceptors in each eye. This was a grid of about 36 points. So it gave some light perception and helped with navigation to a certain extent. So that's one approach. Another downside is a much higher complication risk from such a surgery. And if you were to have something like that, you would usually be excluded from any other clinical trials that were coming down the line a few years later. So there's a reversible option that we've been exploring in Ireland called the BrainPort device. So it's a similar concept, except instead of using vision, it uses a synesthesia, using the sense of touch inside your mouth, connected to a pair of glasses with a camera to give you tactile stimulation that with some training can give you a visual analog. And the good side of that is the cost was a lot less, no surgery, and if something becomes available that you could get involved with, that you just take the device out of your mouth and you still have untouched eyes. It's got a little line on it, just in case.
Okay. What was the name of that product again?
That was called the BrainPort device.
Okay. And is it in trials in Ireland right now?
It's commercially available.
Okay. That was very interesting. I hadn't heard of that one before. I think we have a question. Does somebody have a question up here? Okay, perfect. First here, and then in the pink shirt on the far right, you'll be second.
So I'm the other half of having two kids with Ushers, and USH1D, so one of the big genes that doesn't fit in your viral vectors, as far as I understand it. I guess the question I have is about what we as parents or as individuals who don't see our gene up there in the list, how do we make research move forward for our kids or for, and we have had some experience having been involved with some trials with looking at Italiarin with kind of stop codon read through. Our son donated his cells to have them made into retinal eye cups to see if there was kind of preliminarily some encouraging results, but then it just went nowhere. So I'm not sure what we're supposed, whether is it that we need to kind of obviously being part of a registry, I understand the strength in that, but are we supposed to kind of get on Facebook and find the others who have the same gene and kind of band together and make it or how do we move research forward?
These are excellent questions, and I hear the frustration behind the long time it takes to get anywhere with a new treatment. So the success of Luxturna was very exciting and promising because we hope that we can hop on the same platform that uses, the AAV vector, and gain some of the same benefits. Part of it comes down to how many people are affected by each particular genetic type of RP or Usher syndrome or Stargardt disease and so on. And if it's not the most common type or two types, there is often less emphasis on treatment initially, although there's some work being done on a preclinical basis, as you described with your son's donation. And then if you have a limited number of people when it comes to clinical trials, even if you have a rock-solid idea that should make sense, if you have 12 people in the world with a very rare given genetic disorder, the clinical trial may treat everybody alive that has it. So the amount of funding that goes into is part of it, also the backing and the kind of governmental support. But it's frustrating for us as well, because even though they made it that far, it's difficult to get to the point where we have treatment. And say for a non-genetic treatment, developing a new drug on average takes 17 years and costs $4 billion. So it's difficult to conceptualize that for 300 genes. That's why they're focusing on the top 20 genes at first to try and give the greatest access. But there's an inherent inequality to that approach. But that's currently mostly what's going on in Canada.
Yeah, for what you heard me talk about and what's listed, in my talk about what the clinical trials, are for gene therapy, it's based on those factors, right? It's based on what can I put that gene in an AAV, because the AAV platform, right, has been proven, and basically how frequent, right, how many patients, right, have those, and so those kind of rise to the top as kind of the first round, right, of programs. And for the other strategies, like gene editing or RNA editing, doesn't matter as much how big the gene is. But those are kind of, more sophisticated level. Instead of just delivering a good copy, you have to be targeting specific types of mutations or specific mutations in certain regions. And that's all in good and exciting work too. But then it also eventually it cuts down on the number of patients that might be eligible, right? If you start saying, well, you have to have a mutation in that exon, or you have to have this specific missense, mutation in that base pair, then it kind of reduces the amount of patients that are, eligible. So all those factors, come into play when companies decide, where to focus their, next effort. And so that's why you see in my talk, why currently the programs are kind of limited to those genes is because of all those factors.
I just wanted to mention something about the registry, since you mentioned the registry. So for individuals who don't know, there is a registry in Canada called the Fighting Blindness Canada Inherited Retinal Disease Patient Registry in Vancouver. Kevin Gregory Evans at Vancouver General Hospital is the site. And the importance of the registry is that it helps show scientists as well as industry the number of patients in Canada who have a specific gene mutation or type of disease. So it really does make it a bit easier to recruit clinical trials to Canada, or if a treatment becomes available, to contact those patients when there is a treatment. It isn't the end-all and be-all, of course not, but it does do a little part to making it easier to bring treatments to Canada and then to access them. And if you want any more information, you can either talk to me or to another member of staff, or of course go onto our website as well. I think we had a few more questions in the room over on that side. I think the lady in the pink shirt, yes.
Hi, my name is Helen. I have a question about macular hole. This macular hole is caused by severe short-sightedness or myopia, which makes the eyeball elongated. And so the retina is unable to wrap around the eyeball, and it splits open at the center, causing a macular hole. In my case, I later knew that this was partly caused by hereditary issues. And I have been seeking assistance, but and then in the meantime, when I get older, I also get the macular degeneration. So, but I have not been able to get anything out of this. I had surgery done to each of my eye a few times, but it didn't help because, I think it's just like, the person gets fat, put on weight, and then still wear the same shirt, and so the shirt will split open at the seams, something like that. I wonder if anything has been done, or is this has been looked into, or is this a so rare situation that it has not been, anything has not been done?
I might be able to help. I can speak to you afterwards in a little bit more detail. So macular hole is a relatively common condition in general. but I believe you're affected by something called myopic macular hole, and that's the type associated with short-sightedness. And that's why being myopic is a risk factor for many eye conditions, from glaucoma to cataracts, macular hole, and a variation on macular degeneration that may happen at a younger age. So as you described, if you're very short-sighted, your eye can be quite a bit longer than the average person, but you still have the same amount of eye to go around. So the tissues can be a lot thinner, including the retina. And you can develop this macular degeneration, sometimes so thin that it causes a hole in the retina. The surgery is aiming to try and close the hole, which may only be successful 75 or 80% of the time, even with excellent surgery. And then when the hole closes, you're still missing a piece in the center that is gone for good. So the photoreceptors that you were using to get your reading vision and facial recognition may be completely gone, even though the hole is closed from the tissue around it closing in. The genetic component is largely the myopia, and there's a number of genes that are linked to myopia, as well as your upbringing and your activities, especially in the first 2 decades of life, as to how short-sighted one becomes. So as a retina surgeon, this is how we fill our days, is seeing people with unexpected diseases related often to short-sightedness. I can speak to you more about your personal experience after the session if you'd like.
And we had a question over here.
Hi, my name's Patrick. I guess kind of a two-parter, I guess. The first one is, where would be the best place to find out what sort of treatments are available for somebody with retinitis pigmentosa if we do know which gene is the one causing the issue? And then after that, what would be the best way, if we sort of know what treatments are available or possible, what would be the best way to advocate to get those treatments looked into? And the reason I ask is, my wife was diagnosed with retinitis pigmentosa about 10 years ago, and we found out about the Luxturna trials that were happening, or the treatment, and it took us over 3 years just to get a referral to the genetic clinic. So it's frustrating when you know that there's something available, her sight's decreasing, and it seems like there's no movement. So I guess, yeah, where do we find out if we have to be the ones doing the research in terms of what's available? What's the best place to find it? And then if we can find it, what's the best way to sort of advocate for her to say, this is what's available, we'd like to look into it?
So you're in the category where I would call this the green light database. You have someone who knows what their clinical diagnosis is, retinitis pigmentosa, and in your case, you know the gene that's causing it. So then it opens up your options. And there's 3 categories of treatment I would consider. So the first is the modifiable disease. So things we can treat with surgery, like cataracts, or things we can treat with eye drops or medications like swelling at the back of the eye. The second group would be vision rehabilitation. So these are things you can access from the moment you find out you have a problem with your eyes, rather than waiting for a genetic diagnosis. And then the third category is what you're asking there about the role of gene therapy, stem cell therapy, etc. In Canada, I think the best resources are probably the Fighting Blindness Canada website, and linked to that in the States, the Foundation Fighting Blindness would be the most accessible and relevant to someone who knows that information. And then if you want more detail and finding out how to become in contact or get involved, there's the clinicaltrials.gov website that's quite jargon-filled, and it would be the registry in the States where international studies would register themselves to garner interest and find participants. And it tells you, is it phase 1, 2, or 3, and details of how to contact and the sites that are involved. In BC, the best person to get in touch with is Kevin Gregory Evans, who may be able to link you into people that in Canada or in the States are participating in these trials. And I think those would be my top tips.
I'll just add on before I get to Dr. Yang, if you want to add something. Since we have people online, there are inherited retinal disease specialists across the country. If you go to our website, to the patient registry site, that links you to the specialist, or you can email healthinfo@fightingblindness.ca, where somebody can answer. If you have a specific question about a clinical trial, they can help you find the information and give you more information to take to your inherited retinal disease specialist to talk about more. And Dr. Yang, did you have anything to add?
No, just well said. That's pretty much what I tell my patients. The foundation in the U.S., Foundation Fighting Blindness, clinicaltrials.gov, and then your specialist, right? Reaching out to your specialist, and if you see something, read something, right, they can look into it. They can refer you, right, if needed. I know it sounds like there's some wait period for that, but I think those are the resources that I would also point to.
With delay in referral, I always try and highlight to people that even if we had seen you a year ago or 18 months ago, we may not be any further ahead at that point in time than we are now in terms of treatment. Like Luxturna, although Health Canada approved years ago, has just been reimbursed in Canada, or in BC anyways, and we've just completed the first Luxturna treatment in the last 2 months. So if you were referred 3 years ago and someone had that specific gene and met the criteria for treatment, they may not have had access to the treatment till now.
We have a question from online, which is about the idea of specialists. And this is from Gerard, who says he was diagnosed with RP 22 years ago, and he was under the supervision of an ophthalmologist. But since then, he has just been seeing an optometrist and hasn't seen a specialist in 15 years. So in both of your opinions, how often should somebody with an inherited retinal disease be seeing a specialist, and what's the benefit for that versus their optometrist appointments?
So I would say that someone who has a known diagnosis, if there are no immediate treatment options, should be seeing a retina specialist at least once a year, provided there's no active problems like cataract or macular edema. In the past, so things have taken off in the last 10 or 15 years with the promise and possibilities, but in the past, say 30 years ago, someone would look at you and say, okay, you have RP, there's not much I can do for you, and give you a very discouraging outcome, and understandably, people might disengage from health services. Say, well, what's this person doing for me? What we want to do now is try and break down that bad experience, break down the stigma, and say, please come back. There may be more that we can do, even from a diagnostic point of view, the new access to free genetic testing, and possibly benefits for the family, and seeing what the risk is of having children affected by RP and other conditions. So it's trying to get people back in who haven't been in contact in 5 or 10 or 15 years. And then I think annual would be the minimum.
Yeah, so I think, well said. I think especially if it's 15 years, it's time, because chances are you probably haven't had large panel genetic testing. And for retinitis pigmentosa, I mean, RP65 is one of the causes, right? And there's Luxturna, so it's time to come in, and get checked out. And even if it's not RP65, maybe it's one of the other genes, that we're currently conducting clinical trials.
Thank you. I think we have time for one more question. Is there a question in the room? I think Jennifer is going to walk around. There are a few extra questions, so afterwards, feel free to come and talk to Dr. Stephenson and Dr. Yang as well.
Hi, my question is, what would you recommend that a 16-year-old with Stargardt's could do to preserve maximum vision whilst waiting for medical intervention? So you alluded to diet for a different condition earlier. So there's things mentioned such as diet, anti-inflammatory, sun protection. What can these children do whilst they wait to help protect them, the vision that they have right now, and make them good candidates for the future treatment? Thank you.
Right, so beyond waiting for clinical trials, whether it's gene therapy or one of the neuroprotective treatments, one thing I tell my patients is, number one, avoid high-dose vitamin A because, right, there's been studies in animal models showing that that can actually make things worse. Beyond that, we don't have much other proven treatments, but we often give out kind of just general guidance for nutrition. But beyond that, there's really not a whole lot. We can talk about like zeaxanthin and lutein and fish oil, which we think are good for the macula. Much of that was derived from age-related macular degeneration studies. I would say there's, I think, no harm in doing those things, but it's not proven to slow things down. For clinical trials, fortunately, there is a wealth of medications currently being explored to slow things down, and some of those trials, are actually enrolling pediatric, so younger, patients. So it may be worth kind of asking, to see what's available, in your area.
And a note on vitamin A is that another common condition in teenagers is acne. And there is an acne medication, goes by Roaccutane in Ireland. I'll have to double check the Canadian branding. But it has a higher dose of vitamin A. So by taking that to treat your acne in someone who has Stargardt disease, they may be at risk for causing progression. So just to be aware of that.
I was going to say, I think we're at time, but I don't hear clapping coming from the other room. So maybe we can do one last question.
It just seems like we're under the umbrella of vision being here, but it's so specific at every table, and even within each table, it gets specific. And I'm wondering if there's general optimism in these breakthroughs at some point becoming more of a cross-pollinating solution, or is it always going to be very specific where you get to one, then we're moving to the next?
I think that we're fortunate that there's people in different parts of the world working on what's common for them or what their passion is. So although there are some breakthroughs where some studies and treatments have gotten ahead of the rest, like Luxturna, there are different groups working on various approaches. So whether it's RNA therapy or gene replacement or cell-based therapy for one condition, and then you have a multitude of options. There is a sense of optimism, but I like to call it cautious optimism, where there are people that might take advantage of someone who is desperate for treatment. And we want to make sure that it's evidence-based and that people don't undergo a unproven treatment that may make them worse or cause other health issues.
Yeah, good point. And I think the other point I'd make about your question is that there is some carryover. So Luxturna was a great example of success with the AAV platform, right? And so that's really when the field kind of exploded, right? Is other companies coming in and using a similar AAV platform, and so even though it's different diseases, right? We have companies using the AAV platform to develop gene therapies for age-related macular degeneration, for the wet type. They're using that to hopefully reduce the number of injections that are needed to keep things under control. It's also for diabetic macular edema, gene therapy using AAV, right? Again, to try to keep things under control and reduce the number of injections. So there's carryover into other disease types when you have kind of a proven modality or platform.
Thank you. I'm going to have to call it now because I can see the other group is coming to join us. So I want to thank Dr. Stephenson and Dr. Yang for joining us today.